Hi Raju, how are you today? I hope you are not underwater like we were in Switzerland in the last days.
Well, it's been quite a rainy weekend, but more importantly, a few weeks ago you spoke to me about Euro Cup fever. We have cricket fever. And will you believe it? This weekend, the passengers insisted that the pilot not take off from Goa because they were watching the last 10 minutes of the cricket match. So, this is our cricket crazy country. But let's get to some work now. I once got contacted via a neonatologist by an obstetrician who he worked with. She had sought his help for a lady with a 19-week pregnancy, and this lady who was pregnant had developed intermittent fetal bradycardia. Because of the two-step referral process involved for a family living outside Mumbai, they really never came to come and see me. Michael, what do you think this child had, and have you encountered this issue?
Raju, most likely your patient had autoimmune congenital heart block. And I have seen a few cases we were discussing with our pediatric cardiologist.
So, this entity then belongs to the neonatal lupus spectrum, the other being the skin manifestations we see a few weeks after birth.
And here also I have seen a case with the skin looking like a lupus in a neonate. And this has stayed for quite a while, for 3 months, and then it went away. But correct, Raju, in fact, some newborns can also have mild liver enzyme elevation or thrombocytopenia. But it's usually, like for my case, very self limiting. But there's only one problem which will then last for the life. It's a problem, a heart problem.
So these prenatal cardiac features are the ones we should be fearing the most. And realistically, therefore, if you look, this term neonatal lupus is actually a misnomer because basically this entity is linked to the transplacental transfer of anti-Rho or anti-La antibodies. Now, while these may be seen in moms who have lupus, they could well be seen if the mother has Sjogren. But for that matter, even in asymptomatic mothers who carry these antibodies.
And there, this is a big problem because it's difficult to know who has these antibodies. And in large community studies, it was shown that 1 to almost 3% of the general population may have these antibodies. And this emphasizes the need and justifies the ACR and Canadian guidelines to screen mothers' pregnancy, especially in the first trimester.
So I guess the rationale for screening them in the first trimester is that the heart block commonly manifests between 18 and 24 weeks, just like the mother who I described, who presented at 19 weeks of gestation.
Yes, and then it's important to monitor fetal echo and heart rate between weeks 16 and 26. So the guidelines do not specify the frequency of monitoring in a previously unaffected mother, but in moms where you had a previously affected pregnancy, then you really need weekly echoes.
This is perhaps because the recurrence rate in previously affected pregnancies jumps up to as high as 12 to 25%.
And in fact, at risk situations, daily home monitoring is recommended since early grades of heart block that can convert to the third degree in a day. We have spoken about monitoring guidelines. Let's shift to prevention now, Raju.
Yes, Michael, the ACR guidelines do recommend hydroxychloroquine for all antibody positive and especially those with a previous history of affected pregnancies. The British guidelines caution against exceeding a dose of 6 milligram per kilogram per day. And Michael, I think you might have read about IVIG also.
Few non-randomized studies, Raju, and these results suggest that low-dose IVIG does not decrease the recurrence in high-risk pregnancies, where the high IVIG at higher doses would be more effective. Needs more studies.
Michael, we have so far focused on screening, on monitoring, and prevention. Now imagine that you are confronted with that phone call and the fetus has a first or a second degree block.
This is a very important point because what we would like is to avoid that the block will go to the third degree block. And so you could use fluorinated steroids, so dexamethasone 4 milligram per day, for example, in the mother. This will not reverse a third degree block, but may prevent it.
But dexamethasone can be a double edged sword because it may even be troublesome to the mother with creating hypertension or intrauterine growth retardation for the fetus, besides certain other issues. So, obviously, this has to be used with great caution and under supervision.
Yes, this is true, Raju, but here you are in between two difficult situations. And people have tried higher doses of IVIG over 5 days and even plasmapheresis or triple approach.
Well, in this situation, if you try all three, you will never know what really helped. But I guess sometimes rescue becomes relevant.
But then we have to talk about another issue is that the pacemaker implantations. In a child who carries to term, the cardiology team would decide the ideal timing for this pacemaker device.
And also, before the timing, also the need for the pacemaker device. Because living with a foreign body in your heart can itself pose its own challenges.
And now, Raju, based on our discussion, what would you advise the family if they approach you with a second pregnancy?
The first thing, obviously, would be that you screen for antibodies, especially in those suspected to be previously affected, because you may not know why they lost their first child. Only thing is, if they give you the story of fetal bradycardia and the antibodies have not been done, you will certainly screen the mother. Echo monitoring with a specialist pediatric cardiologist. I chatted with my favorite pediatric cardiologist, and he said that there were important techniques of how to pick up first and second degree heart blocks. Hydroxychloroquine for sure if the mother is antibody positive. Dexa for early grades under supervision. What I mean is dexamethasone, and absolutely without negotiation, a delivery at a tertiary care center with the baby being transferred in utero rather than rushing somewhere from some village in the middle of the night with a cardiac team standby next to the delivery suite. And above all, in our setting, funds completely arranged, and otherwise this can also be a major deterrent in our setting.
And what if they do not come back again?
Then, well, my heart will skip a beat.
Okay, thank you very much for this, Raju, and see you next week.
Do you think today's discussion will help you in your practice the coming Monday morning?
Then join the G Academy forum by clicking the link below. We offer new discussion every week on different topics in pediatric rheumatology.